have any questions, write them down, save them, and please do ask at the break. Thank you.
Yeah, thank you.
I will invite Dr. Lama Al-Aswad down. She is the Irene Hines Given and John Laporte Given Research Professor of Ophthalmology. She's coming down to talk to us about AI-based screening for glaucoma.
Thank you. Thank you, Mara, for inviting me, Josh, for this amazing meeting. I always learn from these sessions. I'm going to talk about an overall view of AI in glaucoma for multiple factors. These are my financial disclosures. Just a reminder, glaucoma is a progressive optic neuropathy. It's the leading cause of irreversible blindness. The diagnosis is complex, it's multimodal, and there's no pathognomonic sign or symptoms or diagnostic test for glaucoma. Early detection is critical, but challenging. Progression is slow and variable. And AI has the promise to improve a lot of this, hopefully. But just to get us back to what AI is, it's an umbrella term that explains advanced computer intelligence to try to simulate human intelligence. The concept started in 1940 and coined in 1956. And if you look, AI in general's birth was in 1940, but in medicine in the 1970s. And ophthalmology since the 1980s. It's been 45 years we've been doing work on AI in ophthalmology. That's very important for a later comment. And just for people to know how AI in general learns, basically think of it like a child. You show it a cat, a dog, and multiple times different variations of cats or dogs or breeds, and then at the end it starts identifying them, and then it identifies breeds that you did not show it in the past for it. So it's think of it like training a child about certain things. And there are multiple forms of AI. The big umbrella term is artificial intelligence, but you have machine learning, deep learning, which is a narrower, deeper, more focused on certain aspects. Many, many ways of training and learning for AI. And they're used in different aspects in ophthalmology, and every type of learning is used for certain task or multimodal tasks, as you can see, and we've been doing it a lot in ophthalmology. Now, AI in glaucoma has the potential to improve diagnostic accuracy, improve screening, treatment, prediction progression, risk stratification, decision support tool, improve workflow. So there's a lot of opportunities, but as you know, none of it is approved in glaucoma. I started this from population health, honestly. That wasn't what I started doing early in my career. I was screening in the community using large-scale screening. These are only two of the ones that I started, but I noticed that the manpower was so costly that it was 90% of the cost of my grants. And this is where the idea is automation is very important to decrease costs if we are going to decrease the cost of screening and improve screening worldwide. There's a controversy about the value of screening in the community. And one of the early studies I actually worked on with a group of people is to see if AI can diagnose glaucoma from cup to disc ratio. And we had a second-year resident, third-year resident, 2 glaucoma fellow ophthalmologists and neuro-ophthalmologists read 110 images, and the Pegasus system read it. First of all, the Pegasus was early. This is a few years ago. It wasn't that sophisticated. It took 8 seconds per image. It took the reader approximately a minute and a half to read it. The AI read them in 15 minutes. The readers read them in 2.5 hours. That tells you the efficiency, but this was a simple AI. But honestly, the AI performed better than individuals. The only person that performed the best, and I've said it before to the glaucoma people, who do you think performed the best? Me, the glaucoma specialist, the neuro-ophthalmologist, for second year, or the fellows, third year? The second year resident. performed better than me, actually. My ego was shot. But because we gave them the rules of engagement, basically what they had to look at exactly. And the AI does the same thing. If you give somebody rules, they follow it. The more knowledge you have, the more knowledge bias you develop. And the neuro-ophthalmologists perform the worst. Sorry, no offense, but if you're a hammer, everything is a nail, basically. But not only that, my issue is with glaucoma in clinical work. I cannot predict who's going to progress. I cannot predict who's going to progress fast. I cannot predict what treatment would work best for the patient. And this work started when I was at NYU, because basically we're very reactive in glaucoma. We wait for damage to happen, then we treat. We wait for it to escalate, then we escalate treatment. To me, it's like telling a patient, why don't you have a stroke? I'll give you hypertension medication, let it get worse, and I'll escalate your treatment. Something doesn't sound right in the way we manage glaucoma. Some people might agree with me, some people might not, but we're always putting out fires. This work started to try to see if we can predict, based on archetypal analysis, which is a quantitative way of looking at visual field defect, and you can follow it over time to look at progression, and you can quantify progression over time. And we looked at 500,000 images, and we wanted to know if there are different speed for progression to blindness in different archetypes. And what we noticed, there are archetypes that progress way faster than others. So if you look at the archetype, just one second. I think that's it. If you look at the archetype 7, 15, and 13, they progress faster. If you look at the archetype 10, it progresses less fast. And in 20 years, who's going to get to blindness? So why is this important? If I have a 45-year-old patient and I have a certain defect, I need to know, are they going to progress to blindness in 20 years? If they're 45, it's 65. In this time and age, 65 is a young person, and now they become blind. This is very important for us if we're going to address treatment and titrate treatment to patients. But not only that, we wanted to look at mean deviation. All of us in clinical work and in certain clinical trials, we look at mean deviation. And we wanted to look if mean deviation speed is different based on archetype patterns. And we noticed there are archetypes that progress. This data is 30-year data of 500,000 visual fields. And we noticed there's archetypes that progress much faster annually, their mean deviation compared to others. And this translated to our work here. We got a grant last year for building a trustworthy AI for glaucoma. And some of our work is trying to translate that to better understanding data. So 90% of AI is data, and 90% of the work is trying to organize and stratify data and clean the data to be much better. So if you look at how we look at different things for data, and mean and severity, we look at mean deviation, mild, moderate, severe. And when we're billing in EPIC, we use the ICD-10 stratification for severity. They're totally different, right? But that's how we do it in clinical work. So mild, no visual field defect. Moderate is one hemifield or less, it doesn't encroach on the 5 degrees, and severe 2 hemifields are encroaching on the center. And what we wanted to do is to to look at the analysis of mean deviation and how it correlates with the archetypal analysis. And does it define severity of disease as well? And we looked at 2 data sets. One of them is the GRN, and the other one is the University of Washington data set. And we categorized them based on the ICD-10, which is mild disease, moderate disease, and severe disease. This work is going to be presented tomorrow, so I'm not going to talk a lot about it by our innovation fellow, Al-Muqdad, but we noticed there are a lot of variation. You have archetypes that are severe in the mild. What's worse is in the moderate, you have many mild archetype, percentage of mild archetype, many of the severe at the same time. And the same thing happens with the severe archetypes. Why is this important? We're using this in clinical trial. We're using them in pharmaceutical development. We're using these definitions in neuroprotection. So if you start flawed, your end result will be flawed. This is very important for us because we're trying to clean the data for our AI testing. So one of the conclusion is that we need to build better archetypal analysis that takes into consideration mean deviation, anatomy, archetypal analysis, and other things. The other thing we want to do is try to predict progression in a way that is very reliable. In addition, you can visualize it well for the clinician. And this is work of Win-Win, Vivian, and all the team that was presented at ARVO too. Both were presented at ARVO. And basically what we wanted to do is better understand if we can build a better prediction for progression. What is the next archetype? What is going to happen afterwards? What's going to happen in 5 years? What's going to happen in 10 years? And visualize it. And what's unique about this and got accepted recently as a paper to one of the most prestigious engineering conferences is that you create a set of prediction, worst case scenario, better case scenario, and then you create visualization for it. I'm not going to talk a lot about it because the poster is outside and the team can discuss it further with you. But going back to saying that it's been 45 years that we have been working on AI in glaucoma, and there is no AI for glaucoma that is cleared. AI gets cleared, not approved, partly because of this. Dinah Chin, my innovation fellow a few years ago, looked at, this was published last year, at how many studies have been done for glaucoma and AI in general. We noticed that in 10 years, there were 10,000 AI studies on algorithms for AI. And they've used everything, OCT, IOP, visual field, multimodal, it's all there. And they all, of course, say we have very good sensitivity and specificity. Yes, and you can always get an AUC 92, you could all of that, and sensitivity, specificity. But there are reasons why they're not approved. Just to go back, there's only right now 3 AI approved for ophthalmology, and they're all for diabetic retinopathy. And partly why in glaucoma we don't have that, we have glaucoma challenges and we have AI challenges. As an example of glaucoma challenge, the definition of severity. It's not there. We don't know what it is. It's all across the map. And by the way, there are 15 definition for severity for glaucoma based on visual fields. So just to give you an example. Endpoints for consensus for progression, endpoints consensus for clinical trials, different levels of gold standard, no gold standard. Data sets and sharing is a problem by itself. People don't share data, are not, some people collaborate, others don't collaborate. So these are all things that are affecting us. But then there are the AI challenges too. You have data quality. 90% of AI is data standardization, and the work happens actually in the AI, in the data work mostly, and that's why you have to have good data scientists with you. Data aggregation, biased availability, no consensus on actually output for AI. We don't know, if you look at all the work, we don't have standards to what's considered a good result AI. What is a good specificity? What's a good sensitivity? What's an AUC that is acceptable? Using different types of model. Every model has something different. And then desired, as we said, desired level of accuracy, fairness, and ethics. The other thing that we need to talk about, just one second, it's not moving. Okay. Can you see the map? Oh, now it's getting clear. Thank you. Okay, so as we said, for glaucoma, there are data limitations. We don't have large data sets, not diverse enough. High quality, no. Variability in imaging, modalities, acquisition, and protocols. You have some studies that have that, other studies that have others, and longitudinal information is not great for us either. The other thing is transparency and explainability. It is very, very important to understand how the model was built and what was the scope for it, because that translates to how you can use it. The ground truth quality, who read it? Did it use a reading center? How many people were involved in it? Reference standard, what was the reference standard? There are studies showing, the Greek study showing that in a study of 5,000 people, when they looked back to see if they truly had glaucoma, 60% of the people were diagnosed with glaucoma did not have glaucoma. So we need to look at how a lot of these references were made. Data provenance, explainability, these are all important aspects. This is another project that my innovation fellow looked at, and the idea is to create models and information about the models in a digestible way. As clinicians, we need to understand how the model was built, why was it built, and the population that was used on, so you can use it in your clinical work. And in a little bit, I'll let you know, I'll show you why it's important. And because if you don't understand how it's built, on what data, on what population, what was the intended use for it, then you will not be able to use it appropriately. Just to cut time, now the other thing is we want to make sure that there is fairness, no bias, equal performance among different groups. We need to make sure there's equity and fairness in all of that. One of the studies that we recently published is about testing the importance of inclusion in the data and how well the data is. So one of the things we did is we trained a model, not a great model, but we wanted to prove it's a proof of concept on a data set for hemoglobin A1C, men, women, seniors, young. So if we trained the model on older patient, it doesn't perform as well in young. And if we trained it on young, it doesn't perform as well in older, and then the same thing with men and women. This tells you why inclusion is very important in clinical work. And of course, ethical concepts are very important for it because we don't know who owns the data, did the patient agree for the data or not, and data handling and liability. So in conclusion, AI has the potential to enhance every aspect of glaucoma. Current algorithms perform well in development, but not in real world. It is critical to redefine glaucoma, taking into consideration multiple aspects, and the future is going to be AI and us and human working together to improve data, disease and data management and everything. Thank you. Did I make it? I made it.
I think we have time for one question.
Yes.
Good question. Good presentation. I have a good question. So what specific AI method? Thank you. So I wonder what specific AI method are you using to evaluate the glaucoma progression? And is there any time series method you're using to control the time step?
Yes, so the time series, we did it early on, but this is a confocal, a conformal risk analysis that was created to do the algorithm for prediction for progression and then being able to visualize it.